Okay, so welcome everyone, and thanks for joining the Functional Medicine Group of Santa Monica. I'm Dr. Ben Weitz, in case anybody doesn't know. So I encourage everybody to participate and ask questions, and Deanna has a microphone, so if you want to ask a question, raise your hand, and that way we can ensure that everybody's going to be able to hear it. I'm just going to double check now, I guess we're fine.
It's going.
Okay. Please join our closed Facebook page. Also listen to my Rational Wellness podcast on iTunes and YouTube. We've got some great meetings coming up. I posted the schedule on the Facebook page, but September 28th, we have Andrea Nakayama, and she's really dynamic. She's a really good speaker, and she's going to speak on the 3 tiers to epigenetic mastery and the use of the timeline and matrix from a functional medicine perspective. October 26th, we have Del Bigtree. He's the producer of Vaxxed, and he's going to talk about the dangers of vaccines, and he's going to show, I think, a 20-minute version of the Vaxxed documentary, so that should be really exciting. And then November 30th, Patty Patak is going to talk about practice building, and we haven't narrowed down the topic yet, so I'm going to send out a survey, so everybody check off what you'd like. I'll put the survey on the Facebook page, and also I'm going to send an email. When I send out a group email to everybody, it ends up in a lot of spam filters, so if everybody could list me as, whitelist my name or something like that, that would be beneficial. So the email that I send out about the meetings or the invite and summary doesn't, it's sent out through constant contact, doesn't end up in your spam or other folder. So here's our agenda for this evening. I'm going to introduce the topic, then I've asked Adam Banning from Metagenics to talk about a few Metagenics supplements that can be beneficial for men's health and healthy testosterone levels. Then I'll introduce Dr. Karlis Ullis, our speaker for this evening, and we'll get started. So our topic for this evening is men's sexual health, which follows last month's topic, which was women's hormonal health. Dr. Karlis Ullis will discuss how you can tell, apart from lab tests, with the physical exam if someone has low testosterone levels, also known as hypogonadism. Approximately 40% of men in the United States have hypogonadism, but only 5% of them get treated for it. Dr. Ullis will discuss which lab tests are most useful in the diagnosis of low testosterone or hypogonadism, and also which tests are best to monitor men undergoing treatment. And so these tests include total testosterone, free testosterone, sex hormone binding globulin, FSH, LH, and prolactin. And Dr. Ullis will also cover some of the controversies about testosterone, such as does testosterone replacement increase your risk of cardiovascular disease, and does testosterone replacement increase your risk of prostate cancer? So I sincerely would like to thank Metagenics for sponsoring our meeting since we started 2 years ago. Metagenics has been so gracious, and they've never demanded anything from me, so I'd like to pay them some love. And so we've asked Adam Banning, who's incredibly smart, knowledgeable about supplements, to speak for about 5 minutes first about some Metagenic supplements that are beneficial for men's health. So Adam, would you come on up here?
Sure.
And probably best to sit down, I guess.
Let's sit down. Okay. Thanks, Ed, for coming out. There are a couple of different supplements that can be helpful as it relates to men's performance, as it relates to circulation, and other factors when it comes to men's sexual health. One of the most important things to be able to understand is men these days seem to be going into a metabolic syndrome state. And metabolic syndrome state will have an individual with a gut on them and thinning hair. And look at what we're dealing with here. First of all, if an individual has themselves some thinning hair, there may be DHT. There's a specific enzyme known as 5-alpha reductase, which converts testosterone to DHT. If we can work with individuals to be able to inhibit 5-alpha reductase, that might be a good thing, right? So there are supplements that can be helpful for that. In addition to that, if you have extra body fat on individuals, you have higher amounts of aromatase aromatase, a specific enzyme, which will help in the conversion of testosterone down into estrogen. Many men will be finding themselves dealing with emotional upsets who come in, and they may have the same sort of symptomology to a certain extent as women do in regards to estrogen dominance. So if you're seeing patients who do come in who have thinning hair and in addition to that have a good sized gut on them, they may be converting to DHT, thinning of the hair, and in addition to that, converting down into estrogen with aromatase. The utilization of a product known as Testosterone has both an 5-alpha reductase inhibitor and aromatase inhibitor as well. So what are the applications for this? If people are coming in and they're taking testosterone right now, and they have thinning hair, and they have themselves body fat, these are individuals who are converting very easily and rapidly into DHT and aromatase. Let's see if we can allow them to hold on to more testosterone. That's one area. The next area is taking a look at individuals as it relates to the production of testosterone and having a proper balance of testosterone and progesterone. Now, the concept of roid rage is very, very interesting because roid rage is a state of imbalance, okay? And in the same way progesterone balances out estrogen in women with estrogen dominance, progesterone helps to get a balance out and calm men in the states as it relates to roid rage or having too much testosterone. The utilization of a product we have called His Synergy can be very helpful with tribulus terrestris, which is helpful in regards to building up testosterone. Ashwagandha, very interesting. As an adaptogen, we want to be able to make sure that we don't convert progesterone down into testosterone. How does that work? Really, really interesting. When you take a look at it, when you have an individual who is stressed out, you add an excessive amount of cortisol, then you get big bursts of insulin in response as well. It's part of the fight or flight response. That big increase of insulin makes an enzyme known as 17-20 lyase. That enzyme converts progesterone down into androstenedione or high amounts of testosterone. So you may have lowered amounts of progesterone as a male, and you might have more going on in testosterone. So we want to be able to work with individuals and have adaptogens so they have less of a cortisol response, less of an insulin response, less 17-20 lyase, and less of a conversion of progesterone down into testosterone. And once again, if we have that and an inflammatory state as well and extra body fat on individuals, we're converting into DHT and estrogen as well through the aromatase and the 5-alpha reductase pathways. What do we do in that situation? Well, we can take something called His Synergy with that great adaptogen of ashwagandha, tribulus, and something which tends to be able to balance out both progesterone and testosterone, something called kawach. Okay? That combination of those herbs has been shown to be quite effective as it relates to that. One little insight for you, you can take the His Synergy and you can take it along with dark chocolate. This is where it gets fun, okay? I worked with Dr. Roy Siegel in New York City. We created something called Chocolate Passion, which was actually sold on cruise ships, believe it or not. Basically, this is before we had our Her Synergy formula for women, but what we did with that is we took a Neuchâtel dark chocolate, 72% cacao, and we blended it together with the His Synergy, and we started testing it on married couples. And literally speaking, the questionnaire at the bottom where you have the open free comments, it was like reading something out of a nudie magazine, okay? Literally speaking, these people were having themselves, these nutrients, these herbs activated in hours as opposed to days or weeks by adding the alkaloids found in dark chocolate. So a little insight for you here, you want it to work faster? Add a little bit of dark chocolate. I guess that's my presentation. Thank you. Yes?
Can you put like a little email, at least I would like it,
Uh-huh.
what you just spoke, all the different products?
Uh-huh.
If, I don't know if anyone wants it too, but I'd like you to send it to me.
Okay,
So
well, what we
get
can
an
do is,
idea.
I'll work with Diana. Diana will send it to the doctor, and if you could pass that out there, we'd really appreciate it.
That'd be great. And there's a handout about some of the products on the back, on the front desk.
Thank you so much, doctor.
Excellent, thank you so much, Adam.
Sir.
Excellent. Okay, so happy that Dr. Ullis is joining us today. Dr. Ullis graduated from the Washington University School of Medicine in 1970, and he's established himself as an expert both in sports medicine and in male hormonal health. Dr. Ullis was a doctor for the U.S. track team at the 1984 Olympic Games in LA, for the El Salvador Olympic team in 1988, and for the Latvian Olympic team in both 1992 and 94. Dr. Ullis is on the editorial board for the Journal of Rejuvenation Research. He's published a number of scientific papers, including wrist injuries in roller skating in New England Journal of Medicine in 1979. Dr. Ullis has written a number of books, including Age Right, Turn Back the Clock with a Proven Personalized Anti-Aging Program in 1999. Also Super T in 1999, he's a busy guy, 2 books in 1 year. Hormone Revolution Weight Loss in 2003. And he's now writing Super T2, Doing Testosterone Replacement Therapy Right. Thank you, Dr. Ullis, for joining us.
Thank you for inviting me.
So, why don't we start with when a man comes into your office, how do you first suspect that they might be having hypogonadism or low testosterone?
The obesity is the #1 cause of
Turn your
hypogonadism.
microphone down. Two. Okay, yeah, go ahead.
So this is a worldwide epidemic of obesity, hypogonadism, and sterility. So we have low sperm counts, we've got a lot of diabetes, and we've got a lot of fat people, and who have low testosterone. So therefore, this is why companies are now going to try marketing testosterone, not for other things, but really for maybe weight loss and everything else. So the whole issue of
Yeah,
obesity.
if you hold it
Oh,
down.
like that?
Yeah,
It's better? Okay.
Yeah, I think
That's
that's better.
better?
Yeah.
Okay, so
Okay,
what do you
thanks.
see when somebody comes in? Well,
It's not working at all now.
okay, they're not
There
working.
you go,
Okay.
there you go.
Somebody comes in, they're overweight, let's say waist circumference more than 36 inches, big belly, sarcopenia, I mean loss of muscle in their legs and arms. And there's only one thing you need to do after that. Pull their pants down, check their testicles. If their testicles are small, soft, and they've got hypogonadism, and all you have to do is run a lab to prove that. And I mean, I can predict that because I've seen many bodybuilders. They come in, I know that their nuts are going to be like peanuts. So you see, and after a while, after examining so many testicles, you really get a good sense of what's normal and what's not.
How many testicles have you examined, Doc?
Thousands of testicles. But the other thing you have to do is examine the breasts. So if you go up here and start feeling like tissue or swelling, this could be gynecomastia. 3% of breast tissue, those with gynecomastia, there's 3% of cancer of the breast. You should maybe do a mammogram if they're not getting smaller. And anyway, so that kind of is the epitome of, let's say, somebody with a low testosterone picture. But then there's obviously the subjective portion, which is people come in, the #1 complaint of people with hypogonadism, low sexual interest, low sexual drive. And #2 is going to be fatigue and no motivation. And #3 will be something related to erectile dysfunction. But that is probably the #1 is lack of sexual interest.
So when it comes to testing, I just would like to mention, before you go into testing, that SpectraCell Labs, which I use in my office, they have some incredibly low cost, really effective male hormone and female hormone panels. So you can get the SpectraCell male hormone panel for your patients if they have any kind of health insurance for as little as $40, including the blood draw. So it's really incredible. So Dr. Ullis, what type of testing do you find most beneficial? What particular lab parameters do you like to look at?
I do kind of a comprehensive. I don't make it necessarily, I do make it hormonal specific, but I do CBC because I want to get a baseline hematocrit, because if you give somebody testosterone, they will go into erythropoiesis, which means high hematocrit, because testosterone is an epigen, stimulates red cells. Then I will get a metabolic panel, they see their liver. I'll get an estradiol sensitive. I'll get a DHEA. I will get their lipids, because lipids are also tied, and especially triglycerides. triglycerides are tied into low HDL, obesity, and a lot of other problems. And they're LDLs. And see what kind of coronary risk these people might have. Then you need LH, FSH, prolactin for sure, because, well, I have had a number of patients with high prolactins would not go down with cabergoline therapy, which is medical, and had pituitary tumors and had to have surgery. So that's very necessary if you cannot manage them medically. Then you've got to do free testosterone, total testosterone, sex hormone binding globulin, and thyroid. Hypothyroid people don't make testosterone well. People with high sex hormone binding globulin have very low free testosterone. Normal total testosterone means nothing. If they don't have good free testosterone, they have the symptoms of hypogonadism. So that would be kind of a long PSA. But it's a little bit age related, but I mean, you got to look at the whole milieu of the patient and look at the comorbidities that go along with it. So I do, and then as time goes on, you slim down your test numbers.
That's great. So it's known that in this country for the last 20 years, we've seen a decline in testosterone levels. In fact, I think it's somewhere around a 17% decline in testosterone levels in men over the last 20 years. What do you think are some of the main reasons for this?
Well, again, it's probably obesity related. There was an editorial by Dr. Basine, who's the chairman of endocrinology at Boston University, one of the top andrologists in maybe the country or in the world. And he wrote a paper about the sterile world. And what he more or less said, because of xenoestrogens, endocrine disruptors, obesity, low testosterone leads to low sperm counts. So my intuition or thinking is, it is the epidemic of obesity that's causing this world to maybe become sterile.
And of course, we're aware of all these plastics and endocrine disruptors and environmental estrogens that come from pesticides and plastics and BPA and sodium lauryl sulfate and all these chemicals in our personal care products and cleaning products. So our world is really awash in estrogenic chemicals.
Very true. It's that you can't get away from them. I mean, if you were to measure BPA values on most people would show some BPA in their system. It's everywhere.
Do you ever utilize strategies to help get rid of some of these environmental estrogens?
I just tell these people they've got to use household things to wash themselves, clean their dishes, clean everything inside the house with some natural products, and put natural products on your body. If you're putting these endocrine disruptors on your body, they do get absorbed. So they could ultimately disrupt your whole metabolic system in terms of testosterone.
And you've got to eat organic because the pesticides are estrogenic, and you try to avoid, taking plastic containers and putting them in the microwave, and eating out of plastic, and really trying to avoid plastic as much as you can, on and on. Yep.
Do you think that there's any correlation between a lot of the nanoparticle technology that's in a lot of the skincare products these days?
Well, a lot of skincare products have been taken off because they're carcinogenic, and I think they're also probably endocrine disruptors to some extent. I mean,
you're talking specifically about nanoparticles, or?
Yeah, titanium dioxide and zinc oxide nanoparticles are really unnatural, and they're in all cosmetic products, including sunscreen.
Oh, they're for sunscreen reasons,
well, they're
right?
just real blockers. I mean, they're probably the most popular right now. You see more people with white faces at the beach than the old days with, sprays or whatever. But the white face is the new sunscreen. So zinc oxides, and titanium are probably supposed to be safer than others. But I
they're
don't know
replacing
how to
all these
answer.
chemicals that we know are.
I don't know how to answer your question because I haven't looked at that.
This is that I've read a lot about nanoparticle technology. They're so unnaturally small, they easily pass through
Right.
into the nucleus and are mutagenics.
Unfortunately, the history of these estrogenic chemicals is, the manufacturers go, okay, we're going to take BPA out and we're going to put BPS in, and nobody knows that BPS is estrogenic, and then 5 years later you find out that is, and they put another chemical in that's probably just as bad.
I think the size is important. If it's 100 nanometer or below, that's when it's really micronized, that can penetrate. But anything, a lot of the companies will actually talk about and write it in their websites that it's above 100 nanometers. So that's something you want to do is look in that. I have a question about the sex hormone binding globulin, doctor.
Yes.
I'd like to know, how do you correct it? Because I see that a lot in my patients, that is the SHB.
Well, sex hormone binding globulin, I see a lot as well, and it becomes, in some cases, very frustrating when you can't find the cause, and men just tear their hair out, and I tear my hair out. And you have to figure out, you have to kind of go backward and figure out where does it come from. It comes from the liver. At some point, they've had some liver insult. You've got to look through their whole history for some sort of hepatitis, inflammation, infection, blah, blah, blah. Is that, you know, there's probably a good percentage of people that don't have a real fatty liver, but they may have like 10% fat. But that might be enough to kick off their sex hormone binding globulin, or that has some periods of time of not eating, or that had hyperthyroidism. They may have occult cancer. There's a list that's really long. But you have to go through that whole list. But in terms of what can you really do, I've tried many things. I mean, anabolic steroids will knock it right down. I mean, things like stanozol or one of those, you know, anabolic steroids that are not estrogenic. They don't form estrogen, non-aromatizing.
Also, in addition to that, kudzu has actually a good deal of up-and-coming research as it relates to the modulation of sex hormone binding.
Well, I think this is what we really do need, because we don't really have this I mean, they mentioned danazol and, you know, anabolic stuff. I mean, some doctors just pump up their testosterone to a higher level to maybe get over that, to make their free testosterone get better. But I have had several people using a combination of boron, nettles, and saw palmetto, and they claim to be getting about 10 to 20% reduction. So it's, you know, this is sort of anecdotal. But I would say examine, go through the whole liver, and maybe do a liver detox. I mean, try to clean the liver out, because that's where it's made.
Thank you.
Oh, did you want to ask a question, Howard? Oh, okay.
I say mine at the end.
Okay, so for men who choose to use testosterone replacement therapy, what is your preferred method of administration? Injectable, topical, etc.?
Well, we, you know, in this country, we sort of started out, or most recently, being gels, which you can apply on your neck, on your shoulders. Then you have another product which you can put in your armpits. Then you have a product you can put in your nose, which has testosterone. And the idea being, if they put it in your armpits or in your nose, you're not going to spread it to your children, your wife, and other people. So, but some people may have a pregnant wife. So they'll have to go to injections. And the latest thing in injections is subcutaneous. You take, you know, a little pinch of fat in your abdomen and take a 25 gauge needle and put it at an angle, kind of at about 30 degrees, and inject it that way. And it's less painful than going, first the buttock is like old school now. You go into the lateral thigh, because you can see where you're going. So lateral thigh is kind of, if you look at the injection level of the testosterone in the lateral thigh versus the abdomen, it's the same.
How do you like the pellets?
I don't like pellets because you can't control. If you get too high, what are you going to do? And these people are just going nuts. You can't take them out. So it's really, unless you're an expert on dosing these people, you have to be careful.
It's also not really a science. I mean, like somebody can get by with 6 pellets for 6 months. Other people, in 3 months, it's just metabolized so differently for every patient. And there's scar tissue with repeated injections of pellets.
Well, there is a long-acting 3-month testosterone decanoate injection approved in Europe, Nebido, I think it's Avid here. And certain doctors in the city will give that injection, but there's some concern about pulmonary embolism and other things. So but I would say right now, I have more people turning towards injectables and getting away from the creams and gels. However, compounded creams and gels are cheaper than AndroGel. Since we're talking about AndroGel, there was a lawsuit not long ago. It was just announced that there was a $150 million punitive damages awarded against AbbVie for somebody that took the gel for a year or two and had a heart attack. So anyway, but now the FDA requires to say you can have cardiovascular issues with testosterone. It used to be not an issue. Now there's 3 papers that have come out which are kind of been created a controversy.
What are they constituting, what are they saying is cardiovascular issues? Like, how broad is that? Is it a cardiovascular event, an actual, like, within the patient itself, family medical history, risk for cardiovascular disease? What's the?
It is a matter that it increases the risk of a cardiovascular event and maybe even a thrombotic event, possibly. If you have, you should probably ask your patient, do you have any family history of Leiden factor or clotting factors and so on? Because you do see, I have seen a couple of patients who, they sit on airplanes and they take testosterone and then they come back with a pulmonary embolism or deep vein thrombosis.
So it's, family medical history?
Well, family medical history, and then getting an evaluation of what is their risk factors for cardiovascular disease.
Okay, so it's family medical history.
And risk factor analysis. If you haven't done, at least a risk factor analysis, like if they've got, LDL cholesterol of 200, well, that's pretty bad. If they've got triglycerides of 400, that's bad. So, you've got to do some risk analysis. You just can't
However,
blindly treat them.
You can treat most of those risks,
Right.
Yeah.
both medically, pharmaceutically, and also with supplements and diet. The studies that came out in 2013 that led to the statement that, it caused cardiovascular disease, the studies were deeply flawed. It was actually meta-analysis, and they didn't check hematocrits in a lot of these patients. They didn't even check estradiol levels, and they didn't follow up some of these patients with testosterone levels. So the studies were deeply flawed. But it got headlines, and then later on, the FDA said, we got to put a black box warning on this. But it was not really based on scientific data. And there's enough data out there that testosterone actually has some beneficial components that help the cardiovascular system. So it's a mixed bag, but I think I've never had a problem, and I have a large cardiology practice, and a lot of them are taking testosterone.
I think measuring the hematocrit levels is really important.
Well, you have to
because-
follow
Very
this.
important.
If you don't follow it, you get in
before and
trouble.
after every visit, I do that.
Because if you get over 50% hematocrit, you're in trouble. Or you're not in trouble, you could be in trouble. The other thing that you're going to watch
anybody
for
who-
is ferritin levels.
Hey,
I
Doc,
didn't mention that.
For anybody doesn't understand, can you explain what hematocrit levels are?
Hematocrit is the thickness of your blood. It's, when you put it in a test tube and the blood just, goes to the ground and you got this much blood instead of this much. It means you've got more red cells.
Right, essentially the testosterone increases red blood cell
Well, it's
production.
an epogen. Like epogens are
Right.
drugs used to increase red cell production through the kidneys. That's where it's.
Are you suggesting
Secreted.
that your patients on testosterone become blood donors? They go and have.
Well, sometimes if you have any problems, I send them to blood banks, but if they have had any medical problems, or if from out of the country, the Red Cross won't take you. So you have to send them a letter to the nearest hospital for a therapeutic phlebotomy, and you have to put down your goal of what hematocrit you want and where they're at, and the follow-up and so on.
Do you find that hematocrit levels impede you from getting to the testosterone dose that you want to in a lot of patients? And are there any other options besides?
Could you bring up the microphone?
Well, in terms of hematocrit, keeping it low, or?
Yeah, do you find that you can't go high enough with the testosterone because of the hematocrit level? Does that happen a lot?
Well, it happens less with gels and creams, but more with injectables. But injectables are actually more potent for bone building and other factors. So there are some patients of mine who I think have some sort of underlying polycythemia where they make more red cells than usual. In other words, they don't need much of a trigger to make red cells. And you give them a little testosterone, they make a lot of red cells. Other people, you give them a lot of testosterone, they're normal.
Don't you feel that it's very individual? There's
Yeah,
some
it's
that
very individual.
No matter
They're-
what you do, they never seem to have a budge in their CBC.
That's true.
Mine.
That's true. Everybody's bone marrow is different.
And there's actually some really interesting data showing patients with heart failure get a significant improvement with testosterone therapy.
The other thing is that I think is interesting that I've noticed in my practice is that with testosterone over a period of time, ferritin levels drop. And these are guys who have been eating red meat, but I tell them to go off red meats, but that contains iron. It's my feeling when they're making so many red cells all the time that they're actually depleting their iron source. So some of these men, I tell them, you know, maybe you gotta get some natural iron in your body.
Are you using, you talked about the gels and the
Hey, Eric,
injectables.
better bring you the microphone so everybody can hear. Thanks.
You've currently talked about the injectables and the gels. In your practice and in your expertise, depending on their levels, are you using anything supplementally natural before you go to the injectables or the gels, or are you hitting them right
Well,
off the top?
I mean, if you have somebody who is, okay, you've got 3 issues. Number one, what drugs are they on? If they're on opiates, which is just an epidemic, as we see in the paper, and if you're on an opiate, you can't make testosterone. And once you know, so all these people out in the street have low testosterone. It's a very interesting story. I had a patient who was in rehab, and she was telling me all these guys in rehab, as soon as they were there for a couple months, got really horny. Well, the explanation is they stopped their opiates, and their testosterone went up, and their libido went up. So there's a big connection, and there's many drugs that people are taking which stop testosterone production. So the drugs are, I mean, there's a whole
What are some of the other common drugs?
well, there's your antipsychotics, and there's Tagamet, your H2 inhibitors, spironolactone. I mean, it's like you have to really look at each drug that they may be taking. If they're even the statins are thought to be maybe related. So it's a big plethora. So the other problem being the other factors you have to look at is things like sleep. People, it's been shown that if you sleep 5 hours for 7 days only, your testosterone goes way down, and your cortisol goes way up. And cortisol and testosterone are like this: cortisol up, testosterone down. So they go yin yang, back and forth. Therefore, that means stress and your stress management and how you manage your life, how you manage your relationships, how do you manage your finances. You know, all those things play into your testosterone levels. And your testosterone, young men in the morning might be like 800. In the evening, it might be 600. Because there's a variation in younger men. In older men, you lose it. And the other important thing is, I ask the men, in terms of success of outcome of treatment, do you get a morning erection? If they do, you know you're on the right path of therapy. Real basic question.
I have a quick question about you mentioned that the spironolactone drops the testosterone levels.
Mhm.
I have a patient, a woman with PCOS, and she's on spironolactone, has been for a while. Recently tested low for testosterone, so she's been put on testosterone. Is this just a vicious cycle? Like, is she just going to be, those 2 levels just going to be fighting each other this whole time, or is there something?
Well, that's interesting, because I deal with a number of patients who I call excess androgen patients. I had one woman who had testosterone of 400 or 500, and they did all kinds of scans on her body. She had to shave all the time. She was miserable. She was sweating all the time. But, you know, so that's excess androgens. But if spironolactone blocks the receptor, it doesn't stop the synthesis of testosterone. So this is a little bit of a mystery, because the mechanism is, it's a diuretic. It will cause potassium to go up, but it shouldn't really occupy the receptor to the point of where or stop the synthesis.
Okay.
I don't get that.
Yeah, I mean, it doesn't really make sense to me either, but it's.
Well, anyway, it's kind of, unless her receptors have changed or something else has changed in her system, her physiology, then I don't know.
Yeah, it's interesting because PCOS is generally thought to be
High
related to
testosterone.
increased testosterone.
Right.
Well, yeah, it's an excess androgen syndrome. The women come in with beards and no hair. I mean, that's an extreme case. I mean, I'm being joking a little bit. But since we're talking about androgen receptors, the new physiology of testosterone is to determine whether you have short and long CAGs. CAGs are polymorphisms in the exon 1 of the androgen receptor. If you have a short CAG count, these are polymorphisms of the androgen receptor, you're going to be a different kind of male than one with a long one. And different kind of male being, there's an article written in a journal of, International Journal of Sexology, saying how much of a man are you? How male are you? And they are suggesting you should titrate your testosterone dose to the androgen receptor. If you have a short receptor, you don't need a lot of testosterone. So you can see some guys getting a big boost out of very little testosterone. And some guys need a lot.
I saw your video on using Clomid and so forth. I mean, I've had a lot of men that aren't really truly hypogonadal, but they're pretty low and they're functioning at a less than level. Of course, I would never use testosterone on them, but if I can augment their native testosterone, I'll do it. So I've used combinations of HCG and Clomid quite successfully. But so you tend to use Clomid a lot, and I think you use it ongoingly in these patients.
So
because I
Doc,
do
can
it.
you explain what Clomid is?
So Clomid is a SERM. It's a selective estrogen modulator. Selective estrogen
receptor modulator.
Thank you. So it's actually a fertility drug for women, as is HCG.
Right.
But in man, it happens to work on it actually works in the pituitary by increasing your LH levels, which then go to they have this hypothalamic pituitary testicular axis, so it actually ultimately leads to increased testosterone. Now I've used it in conjunction with the HCG. I'd like to hear your opinions on how you do that.
Well, I sometimes don't like using HCG with clomiphene citrate because because HCG is LH, and you're trying to create LH upstairs, and yet you're giving LH downstairs. So it would kind of cancel itself out. So, however, if you're going off of like HCG, it might be a good idea to start introducing clomiphene citrate. And I would start usually at 50 milligrams every other day, but men do not like clomiphene citrate because it's estrogenic in terms of psychology. I have some men telling me they watch a movie and they start crying because it's something, when they've been on Clomid. So, they get tearful, so they just can't handle it. So there's a subset of men who are very sensitive to clomiphene citrate. So, then I have some men who have used Clomid for many years without problems, or down to 12.5 milligrams every other day with success. And the only other problem is that it raises sex hormone binding globulin, lowers IGF-1, will raise hopefully LH, but these are some of the downsides. But there is in development stage 3 repro pharmaceuticals called enclomiphene, which is a transisomer. And if that gets approved, should have been approved a long time ago, you won't have these sort of tearful men. You'll just get fertility, you'll get bone density, and you'll have higher levels of testosterone.
Yeah, she's got a microphone there for you, Roseanne.
Hi, you began to touch on something I was sitting here thinking about. Is there a trend in male hormone application to do genetic testing, to look at SNPs? That's what we're starting to talk about. So you're talking about epidemics within the general population. However, I would want to look at that to see, we're talking about dosing or predictability, about how different men would utilize particular supplementation drugs, et cetera. So is that within your particular field?
There was a very good paper written on that subject. Is like, should we titrate the testosterone level to your CAG receptor? In other words, if you got a long one, you're going to need more. If you have a short one, you need less. But we can't do that. And I even talked to LabCorp about, can we measure them? And they just said, well, it's not going to be, we're not going to make money or something, bottom line. So, but it would be very interesting to know that, because the long CAG, or the long androgen receptor, also has more diabetes, more obesity, and so on. But you will see men that come in and say, look, I've got my number up to like 800, 900, 1,000, but I still don't feel well. Maybe they have one of these polymorphisms, and they may need 1,500 to feel well. So and a lot of doctors get scared if that level of testosterone goes over 1,000. I've had patients up to 3,000, 4,000 and doing fine.
Would you happen to know if that SNP is included in the 23andMe?
Well, I don't know if that's, no, it's not.
No.
It's not. There's a lab in Germany that does it. There's a guy by the name of, Zitzman, who sort of is the father of this whole concept, and he's in Germany, who's written some papers on it.
So I'd like to bring up the testosterone and prostate question. It's known that men with advanced prostate cancer, stage 4, are often given medication that blocks testosterone levels, and it's thought that testosterone causes the spread of prostate cancer. What's your opinion about the whether taking testosterone increases your risk of prostate cancer.
I will answer that question after I say something else.
Okay.
About the cardiovascular risk, there's just in January, July, in JAMA was published a coronary artery calcium score looking at men on testosterone topical 1 year and placebo, and it showed the men on testosterone had higher degree of what do you call it, plaque that was non-calcified. So now there's a big debate, based upon that study. There's another, thing to talk about. In terms of the whole issue of prostate cancer.
And non-calcified plaque is more dangerous.
Well, it could be, but
Right.
then it could be.
It's a
So
really small study.
there's some debate about that. So whether that's a problem or not, but anyway, it's still like a data point out there which cardiologists and other people are getting excited about. So getting back to the prostate cancer, I mean, the original prostate cancer idea was based upon one person in the 40s who had his testicles taken off, and he got much better in terms of his prostate cancer. So that means that, prostate cancer is kind of like if you throw testosterone in a fire, you're just creating an explosion. That has been the prevailing thinking for the last 60-some years. It was just in the last 3 years that I think it was Morgenthaler from Mass General who came up with the saturation theory, said that, look, prostate's like a sponge. You can only give it so much, any more than that won't count. So high testosterone was associated with more likelihood of cancer. Not true. If you give it too little, it's actually more of a problem. So low testosterone was sort of found out to be more highly correlated with prostate cancer than high. Therefore, I have a number of patients who have been diagnosed here at UCLA with prostate cancer through the new multi-parametric MRI system. And then you can see the cancer, the growths, and they've been biopsied, and they've been Gleason scored, and so on. And I talked to Dr. Marks about this, and he said, well, you want to treat? Go ahead, we'll just keep watching him, and come back in a year, we'll do another biopsy. So this person, actually, I'm treating him with, there's some patients I don't even treat with testosterone, I just use HCG. And HCG is actually, compared to testosterone, creates greater libido, sexual desire. The reason being, you're dealing with exogenous testosterone, one molecule, but when you use HCG, you're releasing DHT, androstenedione, estradiol, testosterone, and a whole orchestra of substances. And that, most men, when they're on HCG for 2 or 3 days, they get their libido up.
Is that injectable?
It's injectable subcutaneous.
There's also the whole estrogen question with.
Well, it raises
prostate
estrogen
enlargement,
more
prostate.
than testosterone does. So you have to be a little careful in terms of maybe you have to add some anti-estrogen drug, because it does shoot it up. But anyway, HCG is kind of like becoming more favorable to men than plain testosterone, because testosterone you feel good initially and then it kind of dies off. Whereas HCG keeps stimulating the testicles to make your own testosterone, which is totally different from exogenous testosterone. Not the same thing.
Like you say, you're backloading versus front-loading.
Yeah, either way.
Ben, you might be going here already, so tell me if you're
No,
going
go
to.
ahead.
But can we talk about the testosterone and obesity link and how one and the other might, like treating obesity might affect the testosterone levels, but also maybe treatment with testosterone can help mitigate obesity?
Well, it is, been shown that if you have somebody who's obese, has low testosterone, you treat them, they do get better. They will lose some weight, but they'll have to do a whole lifestyle program in addition to testosterone. You cannot expect them to just get testosterone and a month later got 10 pounds off. Well, it's not going to work that simple. It's really a multidisciplinary approach is needed. But it helps.
Right, so given that, how can we confirm that it's the testosterone that works? Are you seeing this in people that they make all the lifestyle changes minus the testosterone and nothing's really working, or they're seeing very minimal weight loss and then they throw the testosterone treatment in and then weight's just shedding off? how can you isolate that treatment of testosterone?
Well, you have to look at testosterone and estrogen as well, because there's a lot of aromatase in the fat cells.
Yeah.
And you have this conversion going on all the time, and aromatase favors fat cells. So you have to also maybe add another drug, like an anastrozole, which is an aromatase inhibitor. But these people have to be maybe treated in multiple ways.
Zinc away, I'm just curious, how else can we like drive that cholesterol into the mitochondria?
Drive the cholesterol into mitochondria.
I mean, I'm trying to think of driving the cholesterol.
Acetylcarnitine.
Well, I mean,
Into the
normally that's
mitochondria?
just a pathway of, I mean, cholesterol. Testosterone doesn't say it's stregnanolone, and then it goes to DHT and estradiol. I mean, estrogen. So, I'm not sure how I can answer
I'm just
that.
thinking about the most natural, and just how can we increase the ability for men and women to have more hormone production?
Or I mean, more synthesis,
Yeah,
more
synthesis,
reproduction.
exactly, production.
Well, I mean, one of it's your lifestyle. If you're not sleeping, smoking cigarettes, and drinking all the time, I mean, you're gonna have a problem. So it's lifestyle, and then there are, like ashwagandha is helpful. There is Tongat Ali, which he mentioned ashwagandha. There was another stuff I just read on ashwagandha that seems to be helpful. Tongat Ali seems to be helpful for libido, and there's some study that shows it might help in the synthesis of testosterone. And maybe change your gut microbiome. There are some bacteria, if you add to the microbiome, that will increase testosterone in rats.
Okay.
And also the size of their testes will get bigger.
Thank you.
And there's two particular strains of bacteria, but that's still, not in human development. Except if you go on internet, it is promoted that you should take this certain bacteria form, Reuteri, I think it's one of these, that will increase your testicular size, Sertoli cells, Leydig cells. So you can buy it.
Not surprising to find out that improving your microbiome promotes another aspect of health.
Well, the microbiome, I think the new wave of testosterone will be the testosterone microbiome. We're gonna pay much more attention how the microbiome affects testosterone metabolism and its effects, because the microbiome itself synthesizes a whole variety of hormones, estrogens and other hormones, and they get recirculated. So it's something, right now, the whole thing about fecal transplants, I mean, it's like a very exciting field of medicine. I mean, I think it's the biggest breakthrough we've had in a long time.
Do you see any side effects gastrointestinally with treatment with testosterone?
Not really.
Okay.
It's not a problem.
I don't think any discussion of hormones would be complete without talking about growth hormone. What's your opinion about growth hormone, and when do you think that it, should be utilized?
Well, I think if somebody has, well, first of all, the federal government has a law which says that, it's the only law which says you can only use growth hormone under these conditions, like if you have shortness of stature, this syndrome, Turner syndrome, and so on and so forth. And it's linked to the Steroid Act. And if you don't follow that, you can be busted, and then people have been busted for prescribing growth hormone without doing a growth hormone stimulation test. In other words, you've got to stimulate the pituitary with glucagon and some other amino acids and show that the pituitary is dead. Then you're allowed, technically, legally, to prescribe growth hormone. So growth hormone, in general though, if you look at the knockout studies of insulin, growth hormone pathways, if they're knocked out, animals live longer, and all kinds of animals. So it's felt that in many, many studies that growth hormone does not promote longevity. It raises glucose. And high glucose is not good.
And IGF-1 may also be cancer,
Right.
When someone's been supplementing testosterone and they stop after a certain number of years, do you see are there any effects that are more serious, or it's something you have to take into account?
Well, that's a good question. One thing, if you're giving testosterone to a young person, It's been reported, let me go backward, androgen-induced hypogonadism. Young men in the gym in high school take a lot of like Winstrol and Decadurabolin and all these other synthetics which don't aromatize estrogen, and all of a sudden their supply runs out. They just go down to the bottom, they get horribly depressed. Parents send them to the psychiatrist. Psychiatrist gives them antidepressants. Antidepressants in teenagers, high suicide rate. So we've seen a bunch of young people die because they stopped their anabolic steroids. Well, in terms of the normal natural testosterone, you have to be careful that they may have an androgen withdrawal syndrome. You can't just drop them and just say, oh, you'll be fine. And the other question would be, they kind of get used to the feeling, and when they don't have the juice, they don't feel well. So it is a big question of like, when and how do you wean them off? I mean, there are these various protocols that are out there on steroid cycles, and you can use steroids for X number of weeks, and then you do HCG, then you do Clomid, then you do this and that. But this is a little bit different in terms of natural testosterone. So it's a little bit of a dilemma. Well, I've had people quit on their own for 3-4 months, and they said they're fine. So I think as long as you're losing natural substances, I've not really had a problem. They went off and said, okay, I got a little tired and this and that, but nothing horrible.
Any other questions? Let's see.
Could you talk briefly about your testing methods and what you're using for, I guess, what values you're treating?
Okay, one of the things I find in the community is that people are treating, they're not determining the type of hypogonadism. You've got really 3 types, I mean 2 main types, like primary and secondary, then functional hypogonadism. So doctors are treating numbers, but they've never answered the question, what kind of low testosterone do you have? Are your testicles working? How well are they working? What I do with those patients is give them like 10 shots every 3 days of HCG, do a baseline, and then compare them like 30 days out. If they start at 250, go to 750, your testes are working fine. You just need some LH. So that's a good test. But if you get a 0 or they're just flat, well, they've got dead testes and they probably need replacement lifetime. The other issue is how well is the pituitary releasing LH? You can do a Clomid test on them. Give them Clomid for 3 weeks. If their LH starts at 2 and it goes up to 10, well, you've got a functional pituitary, but there's something wrong in the hypothalamus. So you've got to do further investigation on that. Or you've got to use maybe something like Clomid for a while. But, so there's these 2 testing methods that are, I think, highly valuable to identify where the problem is.
Do you always test testosterone in the morning?
Well, you really, you should, because the numbers are going to vary in younger people, 150 units between morning and evening. In older folks, there'll be probably the same, not that much variance. But always, some people will also recommend you do 2 samples to verify it, depending upon the lab you use and how reliable it is. And if you're using the LCMS-MS method, you'll probably get a reliable result like from LabCorp, but other people use different kinds. So it's probably best to confirm a low testosterone with a second level done.
Yeah, you showed me that paper where a number of doctors are prescribing testosterone without even testing. They're just taking patients who have symptoms of low testosterone and utilizing it.
Well, this is the whole thing that AbbVie spent about $80 million on advertising AndroGel, and that's why they also got fined, because they were just pushing it, and there are a lot of these low-T clinics around, because it's a youth factor. It's the fountain of youth and blah, 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 and that's not true. I mean, it isn't.
Do you use progesterone for men?
I have. I mean, and a few men for like if they've got metabolic problems in terms of their, their glucose metabolism might be off a little bit, but I don't use it much. I mean, it's an anti-androgen in a way. I mean, decarorabalin is very close to progesterone molecule in terms of molecular, when you look at the molecules. Anything else? Are we done?
I think we pretty much covered it.
Covered it all?
Dr. Gold?
Do you see a correlation between statin use and testosterone decrease?
Well, there's been papers written. I remember going some years ago to this program put on, actually it was put on by Pfizer, and it was at the Beverly Hills Hilton. It was all about erectile dysfunction. There was a guy talked from England, and he was like the first guy that said, well, listen, you know, there is a problem with statins and testosterone. And he has some data points, but, so there is an issue of when you're treating, well, what does statins do? We know it lowers LDL. LDL is supposed to be the magic factor. If you get it low enough, your heart rate risk goes down. But it also shows that it stabilizes plaque a little bit. But I don't know. You know, problem is that cardiologists have their hands tied. They don't really have a good drug out there. They have that new one, which lowers your LDL down to 30. But then it says less cardiac events. Well, good news, but I don't know. It's an injection once every 2 weeks, one injection.
So the issue is that the body makes testosterone from cholesterol. Is there a LDL level that you like to keep men above? Like, do you ever take men who have low testosterone and maybe utilize therapies to increase their testosterone levels?
Well, I have a couple of patients where their cholesterol is like 105, 104, and it's genetic because we've done all these manipulations diet-wise, just can't get his cholesterol up. So we use pregnenolone as a second step to be able to make all the hormones downstream.
How effective has it been?
Sorry?
How effective has it been?
Not greatly.
And it makes sense.
Well, it makes sense on paper, yeah. But, you know, we've tried all kinds of things to bring it up because there is an association in the literature about suicide and low testosterone. Now, how valid that is, I'm not sure, but there is data.
So is there an LDL level that you'd say, look, you should not get your LDL below 70, or is there?
Well, people, you know, with the new injectable antibody, the PCKS9, whatever, or they brought from 70 down to 30 the level of LDL. I mean, that's a huge drop. And they did it for a year, and they found out these people had less cardiovascular events.
I mean, they came out with these papers at the American College of Cardiology in April, March, how great these PCSK9 inhibitors are because now they're getting levels in the 30s, LDL. These are very short studies, and they're not looking at long-term, you know, what is happening to their brain. You know, they're just letting us know as cardiologists, oh, it's safe, you know, no big deal. And we get the LDLs down, we're going to have less cardio. It's just so much of this. It's crazy.
I mean, I think that if you become a plant-based diet person and follow the book by Azelstein, I don't know if everybody knows that book, but it's How to Reverse Cardiovascular Disease. He doesn't want you to have any oils, sugars,
Right.
And it's like being very much a total vegan, and he's been able to show good results. And I have a cardiologist I work with, he's a vegan, and he tells all his patients to go on a vegan diet. A vegan diet, if you look around the world, look at all the statistics, those cultures on vegan diets have less cardiovascular disease.
Well, it's debatable.
Yeah, I mean, there's
Well,
been a fair amount of
but this is when you look
research.
at, you know, the China study and all those other studies.
Yeah, but there's been an equal number of studies showing that a paleo diet and Mediterranean diet have reduced cardiovascular risk as well.
I don't know, I think that the numbers in China, I don't know, I have to look at the statistics to see which one comes out, but there's been a comparison.
I have a patient that has coronary disease. He's trying to be very proactive. He's totally vegan. He's seeing a holistic general practitioner, and his numbers came back worse. I mean, he has a high calcium score, like 1400, but he's really high, but he's never had an event, okay? So we're trying to prevent an event. I said, I don't think this diet's working for you. Your triglycerides are, you know, HDL is really low, his triglycerides are still high. So you examine the diet, he still has a lot of carbs. You know,
Well, You know, it's just that people are
If
so
they have a
afraid of
metabolic issue,
carbs.
they're not gonna do that great on a vegan diet, depends on what the.
And I think people are so afraid of like legumes, and I think they shouldn't be.
It depends, yeah.
I think it depends on the source of
Right.
how they administer the vegan diet to themselves. I mean, as a dietitian, I see.
Well, there's all kinds of
Variations.
quote vegan diets. I mean, if you look at, you know, the style, some people, you know, may eat rice, may not eat rice, who knows?
Yeah, I mean, I'm sure a lot of you probably had the occasion where somebody comes in on a vegetarian diet and there's no vegetables in their diet. All they're eating is starchy carbs.
Right.
I think one of the things that happened when we had an actual debate between the different diets was, I think it might have been you that went around and said, listen, let's look at the genetics of the individuals, let's look at the backgrounds of the individuals. Let's put the patients in the center of this as opposed to something that we put inside a slot. Because each one of us were like, oh, Mediterranean's right, oh, keto's right. But you know something, if we can find those specific background and genetic factors and also lifestyle factors and also the predispositions as it relates to their current situation, we can come up with an approach and utilize the different diets as a menu as opposed to this one's right for everyone.
No, you're right. I mean, we have the capacity to do genomic studies. I think there will come a day we'll have everybody know their genome. And the guy who developed the genome, Craig Venter, came out over 10 years ago. He found out that based on his genome, he started taking statin drugs. He showed some abnormality in his cardiovascular system. So the genome now is around $1,000, and it used to be, who knows, millions and something. So I mean, all these 23andMe's are nothing, but you know, we will get to more sophisticated. What we need is at the clinic to do a quick genome study and then tailor your diet and your lifestyle.
But I think your point about the statins is, I think it's another factor that's led to this society-wide decrease in testosterone levels is a drive to lower cholesterol levels. And it's also led, I think, to a decrease in vitamin D levels and vitamin K levels. And so I think they all go together because they're all part of, you know, made from cholesterol.
That's true. I mean, unfortunately, I think that, you know, I don't know. I myself am sort of thinking more towards a vegan diet. I mean, trying to practice as much as possible. It's difficult to really be on a vegan diet because you've got to shop differently, you've got to eat differently. You can't just, you look at this food and you go, can I have it or not? You know, you got to play with your mind. And then you go, I can't have that, I can't have this. But what I'm gonna eat later, you know, then you got to plan it out. It's not easy. You got to plan your whole week out.
What about metformin? Does that have any side effects with testosterone? I mean, it seems like metformin now is almost like the statin of the millennium or something.
Metformin does have some issues with vitamin B12 and other things. However, it drives something called AMPK, and AMPK increases energy, cellular energy, and it has, okay, there's a study that I was at the Endocrine Society meeting. They took a group of diabetics who were on 1.5 grams of metformin and placebo group, and the people on the metformin had less prostate cancer, colon cancer, breast cancer. So there is a link of metformin and insulin sensitivity and lower cancer rates. Right. And some places are even using metformin for therapy.
Apple cider vinegar actually stimulates cyclic AMP as well.
What does?
Apple cider vinegar.
Okay,
There's
great.
you know, some tests
AMPK,
that showed and
great.
science has showed. I just have a quick question about DHEA. If you use it, and if you do, how much is the dosage?
I don't really use it in men because the data has shown that men convert it more to, it becomes estrogenic. In women, it's great. I mean, it is the first androgen you should give a woman. You shouldn't give her testosterone, give her DHEA. It's much cheaper and easier to use.
What's the dosage for women?
I mean, I start with 5 and go up to 25. I mean, some women are very sensitive, they get pimples, they lose their hair, and some women don't. They tolerate up to 25 or maybe 50. It's all
What
individual.
about using a DHEAS?
That's the stable form in the blood. I don't think it's that active biologically. I mean, there's 7-keto, but that's a different story. It's about diet and maybe metabolism.
I just wanted to quickly comment back on the diet. And as a dietitian, you know, we practice evidence-based, and so we're along the same lines as UMDs, and you know, looking for hard facts in black and white in research, and it's very difficult. And I feel like I'm constantly trying to remind other practitioners that with research that deals with nutrition, it's you cannot pinpoint it. It's impossible because we cannot starve patients. We cannot control, you know, past experience, genetics, all these things that come into play. So it's hard to say that one blanket diet can work.
Absolutely.
You know, to eliminate disease in one category or reduce the factors. And there's all these other, you know, things that come in, but this is kind of freeing, right? Because it's like, okay, what if, you know, you don't have to be vegan in this sort of box. What if you were, you know, mostly plant-based but had red meat once a month, or you know, pescatarian but still liked your eggs too, or you know, something like that too. So there's flexibility, and it's incredibly individualized with nutrition, and you can lean on your dietitians to help your patients with that. But I will say, I've seen kind of both ways. I've seen a lot more luck, honestly, with the Mediterranean diet if you're going with a blanket approach with cardiovascular disease and reducing the risk factors there. But the vegan thing is getting a lot of hype. What the Health came out, documentary, I hear about it daily, and I'm ready to not hear about it anymore. But anyway, I just had to make that point because it's not, we can't lean on research to dictate nutrition practices. It's individualized.
And the Mediterranean diet has been studied more than really any other diet as far as the benefits are
You've
concerned.
got 3 out of the 5 blue zones, which are, if you're familiar with that, that's the 5 places in the world where people live the longest, as most centenarians, and they're practicing mostly Mediterranean diets, and not by, you know, force, just.
But they all live by the sea, so to speak.
Right. Yeah.
Sardinia, Okinawa, etc.
Yeah, and then Loma Linda, California, where they're
Yeah,
Seventh
Loma
Day
Linda, right.
Adventists and leftover vegetarian, so.
I just wanted to add that I had the pleasure of attending a Weston A. Price Foundation conference a few years back, and a featured speaker was a medical journalist who was bothered when she read the China syndrome, China study, yeah. And she went deep with that and investigated the fellow who had done the study and then written the book. Okay, whatever, okay. And she was pretty convincing in that there had been some kind of issue with tenure at his university, and that he had altered facts and figures to the study, and she pretty much debunked it. She went to the areas that he was saying these people eat this way and they didn't, and et cetera, et cetera. So if you want an evidence-based practice that would involve any kind of vegetarian diet, and you're using that as a reference, I don't know, I mean, that's stuck in my mind forever.
That's a good point.
And I also, this is just my observation, but in my practice, I like what you said, Ben, because I haven't been a vegetarian yet. And all these people calling themselves vegetarian, I said, could you please define that for me specifically as to what you are eating? And then, you know, everyone's doing it differently, so everyone's sort of determining by trial and error and their personal philosophy and their personal taste, and how many times I've been to dinner with someone, they say I'm a vegetarian, they're eating long beans and rice and 3 glasses of wine and a piece of chocolate cake. I mean, that's not a healthy diet. It's so variable. And again, I'm going to sound like a broken record, but I really think the whole genetic testing is where it's at increasingly, because exactly what you said, sir, that for $1,000 you can have your whole personal genome done, you can look at it, and then you would know, and not just that, supplementation, et cetera, not to be scared of it, what diseases you're prone to, but then what genes you would turn on to make sure that never happened. And that would include your diet, et cetera. You know, lifestyle for me is the real medicine.
Well, one of the
When
things-
you're studying medicine, I think medicine is your lifestyle.
One of the things in the world is that we're getting, we used to be sort of like, you know, so much migration going on around the world that the mixture of genes is happening so fast that, you know, it's kind of like unstable worldwide genome. What I'm saying, because of intermarriages and so on, that we're having such a, there's no, I mean, they studied stable, you know, people and stable environments, but now we don't have such a world.
Shouldn't that genetic variability improve health?
I mean, does the mobility of people around the world increase?
Sure, different, highly variable, you know, inbred populations
Well,
are
yeah.
poorer in health.
Sure.
And genetic differences, you know, when, you know, the combination of widely varying genetic traits should almost always prove to result in a healthier
Well,
individual, you know.
Well, it's the best of, you know, I mean, who survives, survival was the best of the, you know, group.
The other thing is that there are no Aboriginal cultures that were vegans. All original hunter-gatherers ate meat. So.
Well, but the question is, they were living in a different culture. I mean, they were not living with cars, plastics. They weren't living with all the garbage you have to deal with every day. They weren't dealing with electromagnetic fields. I mean, they were in the purest world possible. The water was pure, the food was pure, so they were in a junk world, they were in a clean world.
Wouldn't that lead more to like an epigenetic explanation?
Yeah, in a way, because epigenetically speaking, we're transforming our DNA stays the same, but all the histones and acetylation, methylation that goes on changes our phenotype all the time. So methylation is a big thing in science now.
Okay, so I think we'll be wrapping it up unless any final questions. Thank you, everybody, for coming.
Thank you.
Okay, thank you.